Okay, good evening, everybody. We're going to go ahead and get started with our webinar tonight. My name is Karen Ladnier. I'm the Director of Research and Education at the Kurland-Jobe Institute. And on behalf of Cedars Sinai Kurland-Jobe Institute, I want to welcome you to tonight's program. Cedars Sinai Kurland-Jobe Institute is excited to partner with the Long Beach Marathon as the official orthopedic and sports medicine partner again this year. Tonight's webinar will focus on knee health in the long distance runner and will feature Dr. Clint Soppe from Cedars Sinai Kurland-Jobe Institute, Santa Monica location. Following the presentation, we'll be opening it up for questions and discussion. During that time, if you do have a question, you're going to type your question into the chat. So you should be able to see that below on your screen. Additionally, following the program, we do have a pair of Rams game tickets and a pair of Galaxy tickets that'll be awarded to someone who correctly answers a couple of running trivia questions following the program. I'd like to move on to the program and introduce Dr. Soppe. Dr. Soppe, why don't you go ahead and start sharing your screen as I introduce you. Dr. Soppe did his orthopedic residency at Harbor UCLA, followed by a sports medicine fellowship at the Santa Monica Orthopedic Group, and is now part of the Kurland-Jobe Institute. He joined the group following fellowship. He's the team physician for the LA Galaxy 2 team, as well as an orthopedic consultant for Pepperdine Athletics. And thank you, Dr. Soppe, for joining us tonight. You can go ahead and get started.
Excellent. Thank you, Karen, and good evening, everybody. Like Karen said, I've been doing orthopedics here for roughly about 15 years. I specialize in shoulder and knee injuries, and I'm excited to give this talk tonight. We'll go through some common causes of knee pain in runners, and at the end have plenty of time for any questions. So disclosures, usually these are financial disclosures, but for tonight, I wanted to disclose that I am not a runner. The furthest I've ever run is a 5K, so that's probably embarrassing to most of you out there. I have treated a lot of runners, and honestly, they're probably, you guys are probably some of the hardest patients to treat. I always am a little nervous and reluctant to tell a runner that, look, you got to quit running, because I can see that look in their face and they're thinking like maybe a day or two, and I'm thinking more like 6 weeks. But, I've learned a lot about running through the years, and, this book, if you haven't read it, it's a great book, and I really enjoyed it, especially from a medical perspective, just in learning about the culture of running and how it interacts with the medical side. So I highly recommend it if you haven't read it. So the overview for tonight, we're going to discuss some common causes of knee pain in runners, go over a little bit of the anatomy, when everything in orthopedics always comes back to the anatomy, the risk factors, symptoms, and treatment of these various knee injuries. And the ones we're going to focus on: patellofemoral pain syndrome, patellar tendinopathy, osteoarthritis, and meniscal injuries. And feel free to, if you have any other questions about any other specific injuries at the end, to go ahead and ask. So the knee anatomy, these are dissections done by one of our previous fellows, and who spent hours and hours on these dissections, and it just kind of shows the complex anatomy of the knee joint. On the right, we have our IT band that gets a lot of talk and discussion, especially in the running world. I actually rarely see true IT band syndrome, but I thought it was an interesting picture to put up. So the normal knee anatomy basics: the knee it's a hinge joint, but unlike the elbow, which is also a hinge joint, it's got very complex articulation. There's, as well as flexion and extension, there's a little bit of rotation, a little bit of translation. So it's a very complex joint. Tendons attach muscles to bone. The ligaments attach bone to bone. Cartilage is what lines our bones and allows our bones to move with minimal friction. The menisci are cushions between the femur and tibia, and they help to protect our cartilage. the tendons and cartilage tend to be affected most in these overuse type injuries. Ligaments are typically involved more in acute twisting injuries such as ACL tears. So we'll start with patellofemoral pain syndrome. It's also known as runner's knee or just anterior knee pain. It's the most common cause of knee pain, and it tends to cause pain in the front of the knee, kind of this vague pain around the kneecap or behind the kneecap. It's typically worsens with squatting, going up and down stairs. Typically going downstairs is worse. Running, prolonged sitting, we call it theater sign. Somebody, and they're in the movie theater, they've got to sit on the in the aisle to straighten out their knee. And this pain usually comes over time. It's usually not with a specific injury, and it usually is more common in younger patients. I typically start seeing it in patients who are in their 20s, 30s, sometimes even younger than that. It's one of the few things that actually gets better with age. So risk factors, certain people are kind of setups for this, and people who have alignment, like here on the right, we call this valgus, where you're knock-kneed. That puts you at risk. Flat foot puts you at risk, and usually those two things go hand in hand. Weaker muscles. The more recent data, there's a big focus on the hip external rotators, and the internal rotators typically are stronger in a lot of these patients than the external rotators, and it puts our knees in a biomechanically poor position. And that's what we're seeing down here in the lower part of the screen. This is a bad position here, where again we're in this kind of knock-kneed position, and this is bad for causing patellofemoral pain, as well as it also puts you at risk for an ACL tear. This is the more athletic type position that we want to see, and this has been looked at in the physical therapy data, and we can actually make these changes to go from a position of valgus internal rotation, like here on the right, into a more athletic position on the left. I also see this commonly after surgery. And I started noticing this more after I had surgery, an ACL tear, and I'm going up and down stairs, and I'm just dying of this pain, and this pain's real. And looking back at my arthroscopic photos, and I'm like, what did my doctor do to me? And so I see this a lot when we have atrophy. And after surgery, the atrophy happens significantly, and as you get stronger, it typically goes away. But we'll also see this in runners or high-level athletes who increase their physical training very quickly, and they can develop pain in the knee. So the patellofemoral joint has the greatest forces and sees the greatest loads of any joint in the body, and that's why the cartilage behind the patella is the thickest in the body. And this picture here is like a axial slice or a slice through the knee. This is the bone of the femur here, and this is the patella or the kneecap. And the femur has this groove in it. It's called the trochlear groove. And this whole area right here makes up what we call the patella or the kneecap, the patellofemoral joint. And this is the front of your knee. And the forces when you do a squat or going downstairs, they should go through this entire area from what is this, E to F here. It should be distributed through that entire area. And when patients internally rotate, they go into that knock-knee position. This is what happens over here. The femur, what's happening is internally rotating on the patella. And now all of those forces that are the same are concentrated through just half of the joint. We think that this overloading type phenomenon causes this pain. MRIs, they're almost always normal, which is good. And sometimes patients will come in and they complain of this. They'll squat down and they'll complain of this almost like Rice Krispie sound, which we call crepitus, which is really common at this problem. And it's not your cartilage like shredding away. It's usually the cartilage is normal, but you can still have this sound called crepitus. So the treatment is almost always non-surgical, which is great. It's a frustrating problem because it takes a long time to recover from. It can be difficult to work out because a lot of times working out increases the pain, but really the focus is on increasing the hip musculature, the external rotators, your glutes. One of the best exercises is this single leg bridge, and because it doesn't bother the knee, it tends not to irritate you, and it really focuses on working out the glutes. It used to be more of a focus on the quadriceps, trying to kind of pull the patella over, but the hip focus strengthening program has been shown to have better results. Other things to do when you have this type of pain: a short period of rest, ice, anti-inflammatory medications to try to help with your pain so you can rehab, because the pain's real. I've been there. It's real. It can be quite painful. Occasionally bracing. A lot of therapists will brace and tape, and this can also help significantly to decreasing pain so you can rehab appropriately. Patellar tendinopathy, also known as jumper's knee or patellar tendinitis. Patellar tendinopathy basically means a diseased tendon, and the definition of this kind of changed a lot. Before, we used to call everything tendinitis, which really means inflammation of a tendon. And the problem is that later on in research, we found that there is no inflammation there, and that's really the main problem. Inflammation is not always bad. The body uses inflammation to heal tissues. So what the majority of these issues are now, we call it tendinosis, which is degeneration of the tendon, or it's like even micro tears of the tendon. All of our cells in our bodies, they're always degenerating, but then they're regenerating, and the regeneration usually keeps up with the degeneration. Tendons just in general have a poor blood supply, unlike muscle, which attaches to tendons, and then tendons hook to bone. Muscle has really good blood supply. It's like a beefy, bloody steak. Blood is always good. If we tear a muscle, like a hamstring strain, it will heal. We never need to operate on it. They always heal. Tendons, though, they don't. When you look at these surgically, tendons are kind of whitish in color. They have a poor blood supply, and because of that, the regeneration of these tendons tend to be slow, and that's why these tend to become like a chronic problem. Patellar tendinopathy or tendinosis, it usually causes pain at the inferior, just below the bottom of the patella. It's usually worse with running, commonly seen in jumping athletes, basketball players, volleyball players. It can again cause pain, and it's really very specific, right below the patella, at the top of the patellar tendon. The pain usually occurs during the activity, and it usually gets better with rest. And here's a very nice MRI section, a side view of the knee. Here's the femur bone, the tibia, and here's your kneecap, the patella. So this is the front of your knee. The patellar tendon is this dark color here. This is normal down here. And then right here is where it happens. You see all this whitish change in the tendon, and that's patellar tendinosis. There can also be like small micro tears in the tendon as well. The treatment is usually also non-operative treatment, focusing on physical therapy, eccentric style exercises, and the majority of the time this works. Again, similar to the patellofemoral syndrome, anti-inflammatory medications, and unfortunately, activity modification for a while, trying to decrease offensive activities and sports that cause pain. Usually this will work. If that doesn't, I'll try second line treatments, such as PRP injections. PRP is when we take your blood, we spin it down in a centrifuge, and we concentrate the platelets. It's gained a lot of popularity through the years with athletes like Kobe Bryant, other athletes, Tiger Woods using this. For tendon issues, it's kind of hit and miss. Tendons like around the elbow, like tennis elbow, it works great. The data for patellar tendonitis or tendinosis, it's in my experience and in the literature, it's been hit and miss. I have had patients that it's worked well on. It is not fun to get. It hurts quite a bit, but it is kind of my second line treatment. These straps can also be helpful, like a Soppe strap you may see some athletes wearing, but they're likely not to assist in tendon healing. And good news, surgery is rarely indicated. What we do when we do surgery, we go in and debride the tissue and repair it back to the bone. A lot of times I'll augment it with PRP, which is what this is at the end, and these are sutures and the tendon. But usually I probably do one every 3 years or so. Patellofemoral arthritis, also it can be called chondromalacia of the patella. Chondromalacia just means breakdown of cartilage. Osteoarthritis is most common cause of joint pain in people over the age of 50. And what it is basically the breakdown of cartilage, the loss of cartilage. Cartilage is what lines our bones. It allows us to move with minimal friction. And classically, it's kind of this slow onset, worse usually in the morning, worse your first few steps getting up. We call that startup pain. But then usually as the joint gets loosened up, it will improve. It can cause swelling, occasionally sometimes like some locking or catching sensations. Patellofemoral arthritis specifically is arthritis behind the kneecap. There's actually like we think of the knee in 3 different zones or compartments: the medial or inner side, the lateral, the outer side, or the front portion, the patellofemoral. And the articular cartilage, again, is this protective shock absorbing tissue that lines the bones. And when this wears down, it will cause arthritis. And the risk factors for this are repetitive high impact activities, increased age, female sex, and a family history of this. Arthritis in general is all about managing the symptoms, because we're not good at regrowing cartilage. If there's a small area of cartilage loss, the majority of the joint has normal cartilage, but it's kind of like a pothole in a street, then we have some good techniques to fill that pothole and regrow cartilage. But when it's more diffuse, like typical osteoarthritis, then we don't have a great capacity to regrow the cartilage with injections or with surgical interventions. So we want to kind of manage this problem best we can with lifestyle changes, weight loss. Weight loss is very important. Every step we take, the knee sees 6 times your body weight. So if you lose 10 pounds, it's like 60 pounds to your knee joint with every step. Activity modification. Sometimes we need to mix things up. I'm not a believer that running causes arthritis or cartilage breakdown, but once you have an abnormal knee, then the impact loading associated with running can cause significant symptoms. And that's where we do mix it up with cycling, swimming, yoga, Pilates, these low impact exercises that are a little bit easier for patients with cartilage loss. Treatments with occasional oral anti-inflammatory medications, sometimes topical anti-inflammatory medications can be helpful. Injection treatments I usually go to next, and there's 3 types of injection treatments that I'll typically use. Steroids, which have been around for a long time, 70 years. They've kind of stood the test of time, but we've learned that there's problems with giving steroids and problems with potentially increasing the cartilage breakdown or are speeding this degenerative process of arthritis. So we do have a couple non-steroidal alternatives that are biological, they're natural, and potentially maybe could help slow down this degenerative process. And those two are hyaluronic acid, which is like a gel or a joint lubricant injection, and PRP again, which again is called platelet-rich plasma, and it's a way of using your body's own natural cells. Platelets are part of the way the body heals. If you get a cut, platelets come, they stop the bleeding, but then they initiate this healing response, release these growth factors, and can help areas that have a hard time healing improve. They typically, both of these types of treatments typically work better in patients who are younger and who have less severe disease. If I've got a patient who's 85 years old, they've got horrible looking x-ray, they can barely walk, these aren't going to work. The end stage of osteoarthritis is replacement. That can be a full knee replacement, that can be a partial knee replacement for if it's isolated to the patellofemoral joint, and we can perform a patellofemoral replacement. And this is pretty rare, but if the rest of the knee looks good, this can work well. I do everything in the knee kind of up to replacement. I have a few partners that do replacements, and I typically would then refer to them. Everybody kind of says something different in terms of what you can do after a knee replacement. Doc, can I try to run a marathon? And the answer is we're not really sure. I think if it's important to you, then you could potentially try or do the best you can, but probably it doesn't make the most sense with a replacement, especially if you're on the younger side. Other treatments I think are good to try. Acupuncture, anything that's been around for thousands of years, even though there's not good data to support it, I think it is worth a try. Local heat and ice, glucosamine, chondroitin, other supplements, and there's very limited data on it. A lot of these products aren't FDA approved, so you don't really know what you're getting. Glucosamine has one good study by the NIH that did show that people with lower amounts of arthritis, and if you take it for at least 6 months, could see some benefit. And now we get to meniscal injuries, and we kind of separate these into two types, acute versus degenerative. And again, the meniscus are these shock absorbers in the knee, and they help to decrease force, decrease stress along the cartilage. So they're very important for long-term cartilage health and decreasing your risk of losing that cartilage and developing arthritis. Many years ago, orthopedic surgeons didn't have much respect for the meniscus, and we've now learned that they're extremely important structures in protecting the joint. The pain typically is if you have a medial type meniscal tear, it's on the inside of the knee, and vice versa. Lateral, it's lateral. It usually doesn't radiate. You can have symptoms like swelling, sometimes catching with a big tear where you have a flap of tissue that's flipping around and can cause even like locking type symptoms. The traumatic tears usually occur with a sudden twisting injury in a younger patient, usually under 35. They're very common with ACL injuries. These degenerative type meniscal tears really just happen with no injury at all. And I'll see these even in pretty young patients. I feel like after kind of 35, this can happen. Patients always kind of try to think back, like, I must have done something, I took that little stumble, but most of the time they just happen. And ACL deficient knees are at much higher risk for developing a meniscal injury, especially on the medial side. And that's why usually in a young, healthy knee, we recommend ACL reconstruction to help protect the meniscus. So the treatment of meniscal tears has, I think, changed a lot over my past 15 years. And it really depends on the type of tear it is. These more traumatic type tears, they much more commonly need surgery, and they're usually done with some type of ACL surgery or other type of ligament surgery. And we've learned that repair is very important. And I fix many more tears than we used to 15 years ago for a couple of reasons. We've learned the importance of the meniscus and preserving it. We've also learned that these meniscal tears that we used to think couldn't heal, there was no blood supply, and without blood, they can't heal. We learned that that's not true. And even though they do have limited blood supply, many of these tears can heal. So I'm much more aggressive with fixing meniscal tears when possible. Unfortunately, just sometimes tears are all shredded up. They've been there for a long time, and you just can't stitch it together, and it wouldn't heal if you tried. The other big change with meniscal tears are in these degenerative type tears that we typically see in a little bit older population. They usually, again, do not have an injury, and they just happen as we get older. And there's been some big studies that have come out over the past 5 years or so, some pretty controversial, but they've shown, I think, and what we've learned overall is that we as orthopedists should and need to be less aggressive with these. I use MRI to help me a lot now with helping patients decide what's best for them, because an MRI now we can see when we've got flaps of meniscal tearing that are out of position, and those are the ones that don't do well. If you've got a degenerative meniscus tear and it's torn, but it's still in kind of the correct position, usually with time, even though they won't heal, your body just gets used to it, and it's kind of just part of our normal aging process. But if you've got a flap of tissue that's out of position, those are the ones that continue to be bothersome and a lot of times need arthroscopic intervention. Probably the best exercise for when you're coming off one of these injuries is cycling. It usually does not bother the knee, and it's a great way to get your range of motion back, get your muscles working. It's good for the cartilage, and progress back into activity. So that's pretty much my rundown for tonight, and I'll open up the floor to other questions. We can discuss these issues in more detail, and or talk about other issues around the knee if there's other questions.
Yeah, Dr. Soppe, why don't you go ahead and stop sharing your screen? And what I'd like to do is, if anyone has a question, let's use the Q&A box to type in your questions. We do have a couple of questions in there right now, which we'll get to in a second. And then, like I said, we do have some game tickets to raffle off tonight. So I'd like to use the chat box, different from the Q&A box, for a couple of trivia questions. I'm going to give you the first one. And again, if you know the answer, you're going to go ahead and type that into the chat. But could I also ask everyone who's answering the question to type in their name and either email address or cell phone number so that we can contact you, because we're realizing the way we did registration, it's kind of blind to us who the people are who are actually on. So before we get to any Q&A questions, Dr. Soppe, we have a pair of Galaxy tickets to raffle off. And, oh, okay, I'm being told the chat is disabled. Our moderator, Dennis, are you able to enable the chat for everyone?
One second. Why don't you go ahead with a question or two?
Okay. So, Dr. Soppe, we do have a question from someone in the Q&A wanting to know, is it okay to run with a compression sleeve on? So maybe you could address sort of, bracing in general, and is that something someone would use while running or as maybe an adjunct, at other times?
That's a great question, and something I get a lot. And there is a little data, showing that compression sleeves can change how our minds, how we, it can give proprioceptive feedback to our brains. Proprioception is how our brains kind of know where our body is in space, even if we don't see it. And it can decrease pain and decrease swelling. So I usually tell patients to, if they're having issues, to try out a sleeve. I think for most knee problems, you don't need more than just a simple knee sleeve, and to try it out. And I have had a lot of patients where they get significant benefits from it, myself included. And so try it out. If you like it, use it. If you don't feel there's any benefit, then you can stop.
Okay, great. So, kind of a broader thing, there is a specific question on this, but I'd love for you to address, if you have knee pain, can you just keep running on it? Should you back off? Should you go see someone, like yourself? Or how do you sort of know once you have knee pain, what should I do now?
Yeah, I think, overall, there's a few signs that are kind of not good. Swelling in the knee. If you see significant swelling, every joint is separated by what's called a capsule. So, and we always have a little bit of fluid in every joint, including the knee. It's kind of like oil in an engine. But when a joint gets irritated, it will kind of go haywire and just make more fluid, and it stays inside that capsule. You can't like elevate it and let it drain out. It stays in there. And it's usually a sign that there's something wrong. So if you have significant swelling, I think usually and pain, that's a reason to see someone, because you've got a higher chance of having like a significant like anatomic problem, like a tear or significant cartilage injury. So that's something I think to look out for. Pain in general, one depends if there's no injury and you have knee pain. I would usually, in no swelling or very limited swelling, and you haven't felt a pop or anything like that, then I would usually give that some time and try to decrease offensive activities. And that could be running, it may not be, but anything that hurts. I don't know if you're necessarily causing further like damage to your knee, but you're definitely going to irritate the knee and prolong a problem that may improve more quickly. My knee patients, like I kind of talked about before, I think going back, if you're running, you're having pain, mix things up. Try cycling or elliptical or something low to non-impact, and switch things up for a little bit and see if that helps.
Great, thank you. Okay, so we are having an issue with the chat box, so we're going to try to multitask in the Q&A box, and I'm going to rely on
Ms. Ladnier, this is the moderator. I do believe we have the chat currently enabled.
Oh, it's working.
Yes, it is.
Okay, all right, perfect. That's going to make my job easier. So before we get to more questions from the Q&A, I'm going to give you the first trivia question. And again, if you know the answer, if you could type your name, email address, and the answer into the chat box. And whoever is the 7th person to answer the question correctly will win a pair of tickets to a Galaxy game. And the question is, what is the oldest marathon held in the United States? So if you know the answer, go ahead and type into the chat box, and we'll continue with the Q&A while people are answering the question. Dr. Soppe, somebody did ask in the chat, if you run a slower pace, if you're a slog or a slug like I am, and you're running, 13, 15-minute mile mixing and walking, can you still develop knee pain, or is that something sort of unique to higher level runners?
No, you can still develop knee pain. Again, there's no data that running actually causes arthritis or causes cartilage breakdown, and cartilage is very durable material, but once you have a problem, and we don't know causes arthritis the majority of times. But once you have it, then everything's different. You don't load through the knee normally. So even a slower jog, even walking, can cause irritation from overloading, of the cartilage, which can overload the bone and cause pain. So for that patient, if you had pain with wogging or whatever you want to call it, and that's causing pain, if you tried to run harder, you will most likely have more pain because you're just overloading more force to a knee that's struggling.
What would be your recommendations in terms of, footwear? If someone is, kind of new to marathoning and looking to be in the right footwear, what recommendations would you have? And, I know that there are certainly running stores that do gait analysis and physical therapists that do gait analysis. Is that something worthwhile, for runners to go out and seek, or, just go to someone knowledgeable who's able to, who knows the shoes and can look at their feet and make recommendations?
Yes, I do get this question every once in a while, and I know it's very controversial in the running world, and I don't feel that I'm honestly an expert on this. And I personally kind of think that it probably depends on your running style, what you're used to. I did see a lot of problems when the whole kind of barefoot running kind of craze came back into popularity 10 15 years ago, and people were going to the shoes with like little toes and all that. And I was seeing a lot of soft tissue type injuries around the foot because I just don't think that patients were ready. Their bodies hadn't had time to adapt. So I think probably if you're a minimalist runner, you stick with that. If you're used to having a soft sole, and I probably wouldn't switch to a minimalist type shoe, or if you want to do it over a slow process, a long time, let your body have time to adapt.
Great. Okay, so we do have a winner for our first set of tickets to give away, and the correct answer was Boston, and the seventh person to answer was Drew Sue. So Drew, will be reaching out to you through your email to let you know how you can claim those tickets. So thanks, everybody. Hopefully everyone on here gets a chance at some point in time to run the Boston Marathon. It's really very special experience. We do have a question in the chat from someone who coaches a lot of younger runners and has had a lot of runners develop Osgood-Schlatter's disease. So maybe you could talk a little bit about what that is and what the treatment for that would be.
So Osgood-Schlatter disease is an issue. There's a growth plate right where the patellar tendon attaches to the tibia, that little bump on the front top of your tibia, of your leg bone. And so your patellar tendon attaches there, and as we're developing it, usually it can cause pain. It's usually boys 12 to 14 years old, and there's a growth plate there. And as these boys are growing quickly, there's an extra stress on that growth plate, and it causes pain. It's like extra tension on the growth plate. And some patients, it'll tend to, the growth plate's kind of on the kind of verge of sealing with bone, and it can get thickened. It can grow with calcification, or just the bone can grow bigger and people can have a bigger or larger bump there. It can be a tough problem for that year or two while the patient's growing and these changes are happening with their skeleton, and they need to work on stretching their quadriceps, keeping that stretched out well, really just symptomatic relief, icing, activity modification, best they can to kind of get them through that time period until their growth plate closes, and then it'll go away.
Okay, thanks for that. What about stretching? We have a question about stretching. Should you stretch before you exercise? Should you stretch after you exercise? Should you stretch before and after you exercise? What's sort of the ideal recommendation?
I don't know if there's an ideal recommendation. I am a believer in stretching before exercise, a short warm up, and then probably stretching again, and usually stretching after exercise. I don't think that you can really overstretch, but yeah, I think not warming up properly can potentially lead to injury, especially if you're a weekend warrior.
Mhm, mhm. You know, for those of you on the call who don't know, my background's as a physical therapist, and we kind of always tell our patients a tight muscle is a weak muscle. If you can put a muscle at sort of the length that it should be at to act optimally, that's how you're going to be the strongest. And so, I would say definitely stretching, but you don't want to stretch cold. You want to be warmed up before you stretch. Let's see. Someone is asking, their knee pops and cracks a lot, but there's no pain involved with that. Is that something to be concerned with?
Nope, it's extremely common, and I see this all the time. I can barely take 2 steps without some joint popping. As long as it's non-painful, don't worry about it.
And then someone is asking if you're considering getting some type of gel injection for knee pain or PRP, is it okay to get it close to the marathon?
It's okay, but I recommend it usually takes at least 2 to 4 weeks for these types of medications to make a difference. So if it doesn't really make any sense to do it, a few days or even a week before. Occasionally, people can get a little bit of irritation from one of these injections for a few days. So I would not recommend doing it within, at least a week, but you really want to do it, a few weeks before.
There are actually several questions in the chat, people asking about what can the causes be of pain in the back of the knee. So not behind the kneecap, but more, in that soft spot in the back of the knee. What would be potential things that you might experience that pain?
Posterior knee pain is relatively rare. When I see this, it can be from a meniscus. Sometimes a meniscal tear in the very back of the knee can sometimes cause pain there. It's common to get Baker's cysts or swelling in the back of the knee, which are usually an effect from a problem in the knee joint, and typically a meniscus tear or arthritis. And what happens is fluid that's inside your knee, and usually the knee's irritated, the knee gets swollen, and then this fluid can leak out to the path of least resistance, which is the back of the knee, and it gets walled off and forms a cyst. And we call it a Baker's cyst. Baker's cysts are rarely painful, but sometimes they can cause some tightness in the back of the knee, especially if you're squatting down or fully extending your knee. So sometimes they can cause some discomfort. Those are the main causes of pain in the back of the knee.
Okay, thanks. We're going to wrap up with 1 or 2 more questions. And before we do that, I'm going to give everyone one last trivia question. And, let's go with the 9th person who can answer this correctly. And again, if you type your answer into the chat and include your contact information so that we know who you are. So the legend of the marathon goes all the way back to 490 BC. And bringing news of Athens' success against the Persians, Philippides gave the announcement, "We have won." What happened next? And if you know what happened next, go ahead and type it in the chat and include your contact information. Dr. Soppe, you can answer.
Good.
And again, we'll be looking for the 9th person who answers that correctly. So Dr. Soppe, we touched on this a little bit in a few different questions, but could you really reiterate for the group, when they do have pain in the knee, how do they know if it's something? Should they just back off a little bit and take some rest time? Can they continue to run through it? Or how do they know they have a serious problem?
Yeah, the other thing I didn't get into, just because it doesn't happen in the knee often, but the S word in running, stress fractures, which are always trouble. And whenever I see an endurance athlete, that's always kind of the first thing that pops up in my head. And it is rare in the knee. Occasionally we can see it, a stress fracture, which is like a micro fracture in the bone from repetitive trauma. And it's rare, but occasionally it can happen in the femoral condyle. So usually this goes hand in hand with stress fractures in the leg too, or foot, is patients, when they have stress fractures, which are serious problems for runners, usually they can't run through it. That's the differentiating factor. Like with shin splints, shin splints, if a patient's running, it will get better as they run. Stress fractures, or what we call stress reactions, which is like a precursor to a stress fracture, it will get worse as they run, and they have to stop running. So they'll tell me, I was on mile 3 and I had to get an Uber or whatever. So that's a really a bad sign.
Thank you. What about ice versus heat? Someone's
Great
experiencing
question.
pain. What's your recommendation?
Yeah, usually for acute type injuries, I recommend ice. Chronic type injuries, I think, can go either way. I tell patients to try them both and see what they like and what seems to work better. Usually after activity, ice is usually better. Before activity, some heat maybe to get your tendons warmed up, joint warmed up.
Excellent. What about supplements? Are there any specific supplements that you recommend for someone experiencing knee pain?
Yeah, I think glucosamine is and it's usually with chondroitin or some type other supplement. I think that's the one that has some data to support it. There's not good literature on supplements, nor do we always know what we're getting. So it's kind of this wild west. I don't think there's, nor have I seen any negatives in terms of taking these. I think so. They're I think safe, but I'm not sure how much benefit there are. If you're going to take anything, I would take glucosamine. I'd take it for at least 6 months to see benefit.
Mm-hmm. And is there somewhere specific, like is the best place to get it in a nutrition store or the pharmacy, or, I know it's kind of an unregulated industry. So how do you know you're taking what you think is in the bottle?
Yeah, that's the bad thing. We don't know. So I'm not sure if it matters where you get it at this point.
Mm-hmm. Okay. It's a big industry.
It is.
Yeah. Yeah. All right. I'm checking with the moderator here to see if we have a winner of the second trivia question. And again, for the second question, we will be giving away a pair of tickets to a Rams game. So very exciting. I want to thank everybody for joining us tonight. Dr. Soppe, that was really a good presentation, great overview.
Oh, thank you.
All the things that can go wrong in your knee. Being a runner myself, I don't like to hear about that. And I definitely don't like all the people who tell me running is bad for my knees and I shouldn't do it. So I like that you address that. It's not the running that's going to hurt your knee. It's bad, biomechanics or prior injuries, etc. Hopefully everyone has trained really well for the race. It's coming up in a few weeks, and I hope everybody really enjoys themselves. So thank you for everything tonight.
I think just my last little blurb here, I've never done a marathon, but I've seen a lot of athletes who do them. They're not easy. So pain is common. I think the good news is all these problems that I discussed, rarely do people need surgery. So that's the good news. I wish everybody luck. Keep training hard and have fun.
Okay, and we do have a winner for our other set of tickets, and we do have your email address, so we'll be reaching out to you and let you know how to claim those. So thanks for everybody for joining. Dr. Soppe, thank you so much, and everyone enjoy
Pleasure.
your training and your race. Okay, good night.
Good night.